So welcome to the next episode of Endoscopy Essentials. I'm very happy to have Roos back, Roos Pouw from Utrecht.
Yeah, happy to be back.
So now we go into your core topic, Barrett's esophagus. So the assumption is we have a Barrett patient, a patient with a known Barrett, and now how do we do surveillance? So we do not start with how frequent, etc. That's a different topic. So we have decided for surveillance and the patient is scheduled. For how long? How long is your time interval you schedule a patient? It's 30 minutes, 45?
We schedule the patients for 30 minutes. And if they have a long segment Barrett, so 10 centimeters or longer, we schedule them for 45 minutes. So we really have enough time to do everything adequately.
And who is doing it?
Well, in our hospital, because we're an expert center, we have 3 gastroenterologists doing the endoscopies. They're all dedicated endoscopists with a focus on Barrett's. So I think everybody has things they like and they like less. And I think for Barrett's, if you want to do the best endoscopy you can for these patients, you need someone who likes to do it, who has a mindset of finding maybe very early small lesions.
So
that's, I think, the most
3
important
people.
thing. Yeah.
So they're always present if you're teaching, etc.
Well, it depends a little bit. Of course, not all at the same time, but at least the patients will be scoped by one of them.
Yeah.
So there's a list and one of them is assigned to the list.
So like for you, do you have Barrett days where you do how many, 5, 10 patients?
Yeah, usually there's 2 dedicated days of Barrett's endoscopy. And usually there's 5 to 10 patients on a list if it's just surveillance. And then we can do some ablation or endoscopic resection in between if there's a lesion found. But it's a little bit how the day looks like.
Okay, I see. But that's an important message, right? So if you're in a specialized center, have your Barrett days and there's the expert there and everything is focused on Barrett. Yeah. It's not like that a patient coming in a long list of dysphagia or dyspepsia. So it's a focused examination.
Yeah, it's a whole theme day. So the nurses also know, well, probably we're going to take a lot of biopsies today. We have the scopes ready for us.
Scopes, always the best ones?
Always, yeah. That's always what I try
Latest generation of...
Yeah, at least high definition white light endoscopy, but you want virtual chromo endoscopy. And we always prepare our lists and then we indicate what scopes we want to use. And we always want the newest, the best ones, because I think the imaging is so important in these patients. And I also tell colleagues who work somewhere else, if the good endoscope is just being washed and you get some old series therapeutic endoscope, you really should wait for the good endoscope to be clean, because the imaging is the most important thing. And the biopsies you can do with any scope, but the imaging you cannot do with any scope.
But that means adapt the schedule to the availability of scopes. So if you have 10 super new scopes, all fine, but if not, you have to match.
Yeah, I think you should look at your program and maybe rearrange the patient order just to make sure that you have the availability of the best endoscope.
Very important messages. Simple but important.
It's very simple. You can do that. You just have to look a little bit ahead, look at your schedule and discuss with the people providing the scopes. But I think that's very easy, so you don't have any surprises or something like that on the day itself.
Next issue is sedation. I remember my predecessor had a co-worker by the name of Uwe Seitz, you know him? And one of his sayings, which I like very much, is that one of the best staining methods is propofol. So do you do those under propofol or which kind of sedation?
Yeah, so the Dutch system is a little bit different from the German system, for example, because I remember from the multi-center studies when I was in Germany in the different centers that all the patients got propofol sedation administered by the doctor or nurse, which in my opinion worked really well. The patients were comfortable and you have time to scope them. So in the Netherlands, we cannot administer propofol as doctors. It's only done by the anesthesiologist. But of course...
That's the case in many countries.
Exactly, yeah. There's not that many anesthesiologists available. So we do have trained anesthesiology nurses who do our Barrett lists, and they can give the patients propofol.
Okay.
So we try to do all the surveillance endoscopies under propofol sedation. The alternative is conscious sedation with midazolam and fentanyl, and that's something we can give ourselves. And if there's no propofol available, we give them conscious sedation, but we always try to do the procedure under sedation because it's just more comfortable for the patient. You can wash the esophagus, you can take your time inspecting, you can take the biopsies. The only reason not to is if the patient is not well enough to have sedation, but then I think you should question yourself if Barrett surveillance is indicated in these patients. Or we have some patients, they don't want any sedation, and some of them can tolerate a lot, which is also fine, as long as the patient is comfortable and you're not rushing through your endoscopy because the patient is uncomfortable. I think that's the most important, but we try to do everything under propofol.
But so there's a clear recommendation to administer propofol if possible, logistically?
Yeah, or at least some kind of sedation. Yeah.
So the patient should be quiet, etc.
Yeah. So you can have peace of mind just to focus on the Barretts.
So what's on the table? What does the assistant have to prepare?
Well, something to dissolve bubbles. We use Infacol, like Simethicone, to rinse. So we have the best endoscope, of course, a water jet. That's the basics. Then, if necessary, we use Simethicone to get rid of the bubbles. We used to give the patient Simethicone before the procedure, but we sort of stopped doing that because it is helpful, but if you're going to do an extensive inspection anyway, you might as well flush with some Simethicone during your endoscopy. So that's what they have available. Biopsy forceps, of course, and we have a cap available, distal attachment cap.
So you start with a cap, or you do no?
No,
okay.
no. So we have it available in the room, but I always start without a cap because it does take a little bit of light away from your image, and it can damage the mucosa a little bit. And I don't think it's necessary in all cases. So usually I start without a cap. But if there's anything I want to inspect in more detail with zoom or near focus and virtual chromo, I just go out and put the cap on and go back in. But it's usually after I've done the overview inspection. And the other reason is if it's difficult to assess the area at the GE junction with the folds, that's sometimes also a reason to put on a cap. But
so if the Barrett is pretty short, it has advantages. But you never start with a cap, you get an overview without.
Yeah, it's easy to put it on if you need it, and otherwise it saves material costs.
So what else is on the table? Biopsy forceps, of course. Staining?
No.
Acetic acid?
No.
No?
No.
No, you don't do that?
No.
Ah, interesting.
Yeah.
Okay, good. Did we forget anything before you start your endoscopy?
No, I don't think so. I think it's...
So it's simple.
Yeah, it's really simple. Yeah, the good mindset. I think the most important thing is I always try to go in with a mindset looking for a needle in a haystack.
So mentality, sedation, good endoscope.
Yeah.
And time.
And water to flush, that's the only thing, yeah, and time.
Some people say, by the way, it might be dangerous because of aspiration to flush. So what's your reply?
Well, you have your endoscope in there, so you flush and suck out the water. I've never had someone aspirate. Of course, they need to be fastened before you start the endoscopy, but usually I do put them in like anti-Trendelenburg a little. So the water you flush goes into the stomach, and you just have to take care to suction out all the fluid from the stomach, also because otherwise it keeps refluxing back into the esophagus.
So very low risk, but quite some benefit.
Yeah, there's a lot of benefit. I think the cleaning is the most important step of the whole procedure.
Okay, I think we are ready to look at some videos.
Yeah.
How that looks like.
I want maybe a nice video to show the cleaning. Let's start with that.
So you are using, just to mention, the latest Olympus generation?
Yes.
Here in that example?
Yes. And then It has really nice high definition white light endoscopy.
So this is a typical image, right? Bubbles and...
Yeah, exactly. So what I would do is I first go into the stomach to check if it's empty. If it's empty, I go up, proximal from the Barrett segment, and then I start rinsing with the water jet, like just slowly from up to down. If there's a lesion, like in this case, I try not to flush on the lesion, because if it starts bleeding, it will be in the way of the rest of your inspection. So once it's clean, so there's obviously a very big lesion. I think everybody would find that lesion. I think the added value of the cleaning in this case is in the rest of the Barrett segment. So after the cleaning and white light inspection, I switch on the MBI. And I'll try to freeze that image for a bit, because I think it's very interesting here. So clean out the stomach in between. And then in this case, there's obviously a big bulky lesion. I think everybody can appreciate that. But it's here very important to clean the rest of the Barrett's, because the actual neoplastic lesion is much more extensive than just a bulky lesion. I think this just shows the importance of the cleaning, because as long as there's mucus and bubbles, you might find the bulky part, but that's not really the only thing you want to find if you want to see if the patient can be treated endoscopically and with what technique. You want to also find the rest of the neoplasia. And in this case, it's very clear that if you look at the picture longer, there's actually a circumferential abnormality with also irregular mucosa at this area. But then if you look even longer, you see that the neoplasia actually extends all the way up to here. And it sort of almost appears as if the change from darker to lighter blue is the top of the Barrett's, but the top of the Barrett's is actually a couple of centimeters more proximal. And I think that small distinction is really easily missed if the esophagus is still covered in mucus. And also, I think the additional value of a virtual chromo shows really clearly.
So if you see that, it needs a lot of experience, right? Because normally you would think, okay, that's the Barrett's and that's the lesion, so I do one CAP EMR and goodbye.
Yes.
And that would be totally incomplete.
Yeah.
So if you don't see that, and if you see that, would you do biopsies to ascertain that this is additional neoplasia, even if you see it?
So I would not. I would understand that someone who's less experienced, and I would be very happy if someone would recognize that there's a difference in color, and if you would zoom in mucosal and vascular pattern. And then I think it would be good if someone would take a biopsy just to, as feedback. For me, I know it's abnormal, it's irregular, so it's neoplastic, and I don't need to have that confirmed with biopsies. Because as long as you can see it, I think you should resect it and not ablate it. And I think these are cases where in the past people, as you said, did the CAP EMR of the bulky lesion, or maybe even the circumferential lesion in the distal part of the Barrett's. But I think that neoplastic area, if you would ablate that, there's quite a high chance that this patient would have a recurrence. And I think those are the recurrences we have seen in the past, because this, with another type of endoscope, you would very easily miss this.
I think that's really mandatory to discuss that, because there's this ongoing discussion whether we see everything to an extent that we can rely and say we resect everything, we don't doubt it. Or in case of doubt, or whether we are not 100% sure, you confirm this with your biopsy. So you would do a biopsy protocol. So if you didn't see that, shouldn't you biopsy the contralateral side, which is theoretically left in place, to make sure that there is no advanced neoplasia? Shouldn't you do that?
Before you embark on resection? Well, I think as long as you can have a good endoscope and you can assess the mucosal pattern and you think it looks normal, then I don't think biopsies are necessary. And in my personal opinion, I think if you're not able to do that, I don't think you should do endoscopic resections. I think you should leave that to someone who is more experienced in that. If you just start training, I can understand. There's nothing wrong with doing it. I would like to say that. But also biopsies are just a sampling. You can have sampling error. Would you do that? Would you?
Probably yes.
Mm-hmm.
Because a circular resection until now is still very prone to bad strictures and that kind of stuff. And you know, if you have a very centralized Barrett management, but if this is not the case, I think better do a biopsy than rely on something which may not be true and say, okay, CAP EMR I can do. If it's more extensive, I send the patient somewhere else. If this decision is made, I think a biopsy is still a useful thing. So we might slightly disagree, but that depends on the setting and other factors.
Yeah, but that I totally agree. So I always try to. So what I'm telling is like the ideal world, and I'm very much aware that it's not the ideal world in most of the situations. And of course, there's nothing wrong with biopsying. Let me say that. I also tell my fellows, if they're in doubt, just biopsy. You cannot do anything wrong with a biopsy, and it helps you maybe. You get feedback on what you saw visually. So of course there's nothing wrong with biopsying, but...
Okay, Roos, this was a very extreme example, right? You had a visible lesion, and besides, you know, flat neoplasia all over the place. Yeah. But the normal situation is that you have a Barrett and you are looking for subtle lesions because they're much more difficult. So you have another example, right?
Yeah. This is an example of a patient who is referred with high-grade dysplasia and random biopsies, and the referring doctor didn't see any abnormalities. And that happens a lot if you work at an expert center. We always say...
That's in favor of my plea to take biopsies, right? So...
So I think during surveillance, you should always take biopsies because it's a safety net. It's a safety net. So surveillance, always biopsies. It's just a safety net for missed dysplasia, and it does happen. And we cannot blame our colleagues because most endoscopists, they don't see a lot of neoplasia during their career because it's rare. And we get the patient referred and we always find the lesion, but it's not really fair because we know something is there.
Exactly.
So
we don't have hundreds, and there's the one.
Exactly.
We have a very enriched population, so it's easier for us, right?
Much easier, and we go in there knowing that there's something. And we look until we find it. So I think that's always a bad comparison because the situation completely different.
Absolutely, but this is where studies are done. I think we should not fake that out of 100 we would find this with a similar accuracy.
No, I'm also convinced of that. And it's just how the world works. So biopsies indeed are important. And this is, I think, a nice example. And I'll start the video. So in this case, I already did the cleaning. So after the cleaning, I have a structured approach, pulling back from the stomach, measuring where the diaphragmatic pinch is, pulling back until you see the top of the gastric folds. Always play around a little bit with the in and desufflation.
Okay, that's very important. Yeah. Length measurement is pretty unreliable, right? So you do it on the scope, and there's 1 centimeter plus minus easily done. But here, you now see it. Here at the top of the gastric folds, this is where the Barrett starts. So you should not add the hiatal hernia.
Yeah, okay. So if you inflate a lot, the hernia often also, you stretch all the folds. Yes. And it's very easy to add 2 or 3 centimeters to the Barrett.
The Barrett becomes longer.
So I'd usually just play around a little bit with the insufflation. I think still the top of the gastric folds and like the diaphragmatic pinch is easy. It moves with the respiration, but the top of the gastric folds is sometimes more challenging, especially if you move around with it and play with it in desufflation. But usually you can, after watching what happens, identify them. We don't use the like the palisade vessels, but what they use, the Asian endoscopists use, because I think in Barrett's and we're not trained like that, so it's a little bit more difficult. Sometimes you see them really nicely, but usually,
especially on NBI, but not always.
No, and I think also it's not like 1 or a centimeter more or less, it's not clinically relevant at all. So
it's not, but you should try to be precise
yeah.
with all limitations. And,
exactly.
yeah,
It's
at
always
least
good
try.
that you see the patient back in a couple of years and you still have the same measurement.
Yes.
Yeah. So, well, in this case, I thought the top of the gastric folds was in this location. And then just slowly pull back, assessing all the Barretts all the way around. Small squamous island over there. And there I thought, well, maybe there's something abnormal
something
here.
whitish.
Yeah. So like the color is different, the surface pattern is a bit different. I do try to finish the whole pullback first, just to get an impression if there's anything else going on in Barrett's. Sometimes do like 2 or 3 pullbacks just to get a feeling of the length of the Barrett's and the mucosa. And if it's easy to insufflate or not. In this case it was a bit difficult to insufflate. Then you get to the circumferential extent and the maximum extent. And those are the things you measure according to the Prague classification. I'll just pause it there. So from the top of the gastric folds to the circumferential extent of the Barrett's, that's the C. And from the top of the gastric folds to the top of the tongues, that's the M. And I always look if there's any like separate islands above that. They're not part of the Prague classification, but I do report them and make a picture. And after doing that, in this case, we saw that there might have been a lesion area that was a bit slightly off color.
Color changes is important, isn't it?
Mm-hmm. Color change, and sometimes you have done the washing and the flushing, you look for color changes. If there's an area that's easily bleeding, can also be a giveaway, and the mucosal irregularities. And also the in and desufflation is important, because sometimes if you have a small lesion, you insufflate a lot, it vanishes.
Yes.
So by playing with the air, you can sometimes pick up areas that are, not moving as the rest.
That all takes time.
Exactly. It takes time and sort of dedication.
Dance with a Barrett.
Yeah, exactly. Sort of a duet. Yeah. And in this case, if I think, well, there might have been a lesion. I put on a cap, as you can see here. You can nicely go back. I'll just start the video again. Or maybe it's nice because in this case I froze the video and you nicely see the demarcation line.
That's close up.
Yeah.
Yeah, but you have to find it.
You have to find it. Yeah.
Where there were some irregularities at 5 above that whitish area.
Yeah.
So you have to focus on all that.
Yeah, you just do the whole inspection again with your virtual chromo. In this case, narrow band imaging and near focus, which is easy. It's just one press of with the button. And it's really, you can really have sometimes you see all the small blood vessels. Sometimes you even, at least I think I see the blood pumping through the small capillaries. It's a beautiful image, and you can see the vessels and the mucosal pattern.
It just looks ugly, right?
Yeah, you recognize it, right?
Yes.
Yeah, but I think there's a lot of classification systems, etc. And they might be a little bit intimidating because often they're a little bit complicated. But I think, as you say, it looks ugly. I think everybody can recognize that the mucosal pattern is irregular, the vascular pattern is irregular. And on the top of the screen, you see it becoming more normal and regular again.
You see a nice transition zone. Huh?
Yeah, and I think everybody would be able to recognize this without using any difficult classifications.
So could you show this when you go back on the video where this was?
The white light image?
Yes, you were mentioning the whitish area, like here. That was the focus?
This was the focus.
But that's huge, right? So was the whole thing changed like that?
Yeah, the whole thing, what we saw with narrow band imaging, the whole area was like that. So if you go back and look at the video again, you can see also there's a sort of a demarcation line here to be seen.
So you go for color changes in general, that can be towards reddish and it can be towards whitish.
Yeah, both ways.
Yes.
Yeah.
Yeah. Okay.
Yeah.
And if we pull back further, is there something else?
I think in this case it was nicely
There's another whitish area here at 6 o'clock.
Just now in the screen, right?
Mm-hmm.
Try to. Yeah. So with the good thing, if you have the cap on your scope and go back in and zoom in and use the virtual chroma, you can assess all these small areas that you saw with white light and see if they're abnormal or not. And if the pattern is normal, then you usually leave it. If in doubt, take a biopsy.
Thank you.
That's never a problem. Also in Barrett's, it's not like you get scarring and you cannot do ESG anymore. It's really not as long as you're not taking 6 keyhole biopsies. It's absolutely no problem to take biopsies.
I think this is a myth, right? That taking biopsies makes everything very difficult.
I would say don't worry about it. It's never been a problem.
Thank you.
I think even what my theory is also when we discussed that we get these patients referred without visible lesions and we perform endoscopy and we find the lesion. What I also try to look for in those cases, you have often these small squamous islands. And I think they're sort of a giveaway. Probably there was a biopsy taken there. And then it heals up with squamous because the patients get PPI and the acid is controlled. I think sometimes these small squamous islands also sort of give away where the neoplasia is.
Interesting aspect. Yeah. Well, at the end, one question is PPI. Because my experience is sometimes, at the cardio and Barrett's, there's this recommendation not to biopsy, but give PPIs. And I remember a few cases where just the lesion goes away, almost. It's almost completely healed and it's much more difficult to find. What's your opinion? Wouldn't you like to take biopsies right away, irrespective of if there's much inflammation, of course, yes. But this PPI thing, it's another myth?
It depends. If it's really very in like grade C or D, I don't think the biopsies you will get just inflammatory changes back. But if you really see a clear lesion, I think you can, because then that probably will be cancer. So you would like to know. But otherwise, if it's just a grade A or B, I do just take the biopsies.
Unless there's severe inflammation which obscures your endoscopic picture.
Yeah.
You don't, if there's little inflammation, you say, I do PPI first and then re-biopsy. No.
But sometimes it's before you start endoscopic resection, I think it's always good to have the inflammation gone because you might end up cutting away more than really necessary because the inflammation just sometimes really changes the image.
Perfect. So thank you very much, Roos, for this exciting episode, and we will be back.